Good morning. I would like to start because we have a very tense program today. It's my pleasure and honor to welcome you in the old city of Poland in Krakow on the 12th International Conference Complex Therapy of Plasma Cell Dyscrasias in 2024. It's our honor that we have today Nobel Prize winner 20 years ago, Professor ARTUR JURCZYSZYN from Israel. Thank you for coming. We have also today Professor SURBHI SIDANA from Stanford University. Thank you. Welcome Professor VAISHALI SANCHOROWALA from the best Boston Medical Center in United States. Welcome. We have also our friend Professor David VESOLE from New York and from Washington. Welcome, David. This is the most international conference because we have also Professor Ramon Garcia Sanz from Spain. Welcome. Welcome, Elena Zamani from Bologna University. Welcome from Italy. And we have our friend Gabor Mikala from Budapest, from Hungary. Welcome. I would like to welcome also Vice Rector Jagiellonian University, Collegium Medicum, Professor Maciej Małecki. Welcome. And I would like to welcome Professor Aleksander Skotnicki, former Chief of Department of the Hematology Clinic in Kraków. Welcome also Professor Wiesław Victor Jędrzejczak from Warsaw University. Welcome our guests from Warsaw, Professor Piotr Rzepecki from Warsaw University. Welcome Professor Lidia Usnarska-Zubkiewicz, also from Wrocław. Welcome other colleagues from Gdańsk, from Rzeszów, from Wrocław, from Warsaw. It's a pleasure to welcome you in Old Krakow, where this university connecting to Nicolaus Copernicus, we celebrate in this year 660 years. This is the oldest Polish university. But I am very happy that we are moving in future because this book you see our new hospital. We changed our place to new hospital 1 year ago, and this hospital, this is the biggest hospital in the Poland. As you see, our title of the conference is Complex Treatment of Plasma Cell Dyscrasia. And we see beautiful progress in this disease, especially in amyloidosis and in plasma and in multiple myeloma. And this progress we can use in new hospital. Exactly for the last 2 years, we have new era in the knowledge. Game changer was bortezomib, of course, 20 years ago, but now we have an era of immunotherapy. Our patients are waiting for new drugs like teclistamab, like elranatamab, talquetamab. This is registered drug, and also for CAR T-cell therapy, Abecma Carvykti. This is another game changer in this disease, and I hope our patient, we can treat our patient with these new drugs. So welcome you in this beautiful town, and I hope you will enjoy not also scientific point and also regarding Polish cuisine, Polish kitchen, and other things. Welcome in Krakow. I would like to ask Vice Rector Professor Maciej Małecki to open officially our conference.
Thank you very much for inviting me here to this conference. I think that the university officials should be both brief and cordial and show the appreciation. So I'm here to show our institutional appreciation to all of you. Thank you very much for coming here. The special words of welcome comes to the faculty. I'm really proud that Professor Jurczyszyzyn was able to build such a wonderful scientific program. And again, special words come to Professor CIECHANOVER. It's not usual that we are hosting the Nobel Prize winner. Thank you very much for coming here. All of you are cordially welcome here in Kraków. I hope that you will be having a good time. This is the 17th century building. It used to be a college or high school in 17th century. And currently, this is the seat of our administration. We are in the process of moving from the city center to the new medical campus in Kraków, Prokocin. And I hope that at least some of you will be able to see this campus. So we are very proud of our past, but we are working hard to build our present achievements and the future. I know that Professor Jurczyszyzyn did his best for the social program, so I'm sure that you will be leaving Kraków not only with new knowledge, but also full of good memories of this country, of this more and more international city. Coming through the market square, you can hear the languages from all over the world. And coming to the end, on the back wall, you see the Copernicus painting. Copernicus is probably was the most famous student of this university in the second part of 15th century. So I'm wishing you all the best, great conference. I'm sure that the Copernicus spirit will be with you today. Thank you very much.
I would like also thank our honorary patronage, which is Dr. Aleksander Michalski, President of Krakow. And also we have honorary patronage for the Magnificus of the Jagiellonian University, Professor Piotr Jedynak. And we have honorary patronage of the consultant in hematology, Professor Ewa Lech-Marańda, and also for the chief of the Society of Loving Krakow, Professor Jacek Purchla. Thank you, our sponsor. We have many sponsors. Thank you, GSK. Thank you, Biocom. Thank you, MPETS. Thank you, Johnson. And as Rector told, I hope Copernicus, who was studied not only in Krakow, also in Padua and Bologna, will be a spirit of our conference. Thank you. I would like to ask for the first chairman of the session, Professor Wiesław Victor Jędrzejczak, and we'll start the conference. Another chairman will be Professor Piotr Rzepecki and Dr. Michał Bator. I would like to ask to sit down. The conference is open.
So thank you very much. Without losing time, I would like to invite Professor SURBHI Sidana to lecture to us on CAR T-cell therapy and multiple myeloma, current limitation and potential strategies.
Thank you very much for the invitation and such a warm welcome, Professor Jurczyszyzyn. I think I will learn how to say that correctly, but Arthur, thank you. Yeah. Thank you very much. This is such a pleasure. My first time visiting Poland. What a beautiful country. We had such a wonderful dinner last night and great to get to know all of you. I hope in the next 20 minutes I can tell you about the latest clinical data we have in CAR T-cell therapy for myeloma, which is truly revolutionizing the treatment and I hope can be available more and more in other countries as well. I know clinical trials may be available here, but as standard of care, hopefully that will be available soon here too. So these are my disclosures. Okay. So in the first part of my talk, I'll review data from clinical trials, but also standard of care use in the real world with CAR T, but then focus on unmet needs, including management of toxicities that are late or unusual, ideal sequencing of immunotherapies with bispecific antibodies also being used for treatment of myeloma, and understanding mechanisms of relapse, as well as talking about newer CAR-Ts in development. So idacaptogene vicleucel, or ide-cel, brand name Abecma, was the first approved CAR-T in the United States in 2021. Since then, it has been approved in different countries as well. This CAR-T cell therapy targets BCMA, or B-cell maturation antigen, that's present on plasma cells and also on B cells. Now, historically, patients who had very relapsed myeloma, which is triple-class refractory or penta-refractory, had poor outcomes. I am not showing that data, but the average response rate for those patients was 30% with everything else, and the average time to progression was about 5 to 6 months, sometimes even 3 to 4 months. So when we had this data from the KARMA clinical trial, which was a clinical trial in very heavily pretreated patients, median of 6 prior lines of therapy, 84% being triple-class refractory, that is refractory to a proteasome inhibitor, refractory to a IMiD, an anti-CD38 antibody. The response rate of 73% at that time was unprecedented compared to historical response rate of 30%. We never previously saw MRD negativity in these patient populations, and here, 26% of patients were MRD negative. And this really ushered in a new era of immunotherapy for myeloma. But again, this is not a cure. The median progression-free survival with this is 8.8 months. If you got into a complete response, it's about 20 months. So yes, these were unprecedented responses, but more work is to be done. And so that was late-line use of CAR T-cell therapy. Ide-cel, or Abecma, was then tested in earlier line use in the KARMA-3 clinical trial in patients after 2 to 4 prior lines of therapy. This was a randomized clinical trial that randomized patients 2:1 to either getting ide-cel or 5 different standard of care regimens. The primary endpoint was progression-free survival. And as you can see here on the lower left-hand side, this trial met its primary endpoint with median PFS of 13 months in the CAR-T arm versus only 4 months in the standard of care arm. They also looked at overall survival. Now, it's important to note that this trial allowed for crossover when patients in the standard of care arm progressed. So on the left-hand side, you don't see any difference in overall survival because many patients crossed over. But on the right-hand side, when you adjust for sensitivity analysis for crossover, you do see a trend towards improved overall survival with earlier use of CAR-T. And this is just an exploratory analysis because many people who were randomized to CAR-T actually never got CAR-T. So when you look at patients who actually got CAR-T when they were randomized to CAR-T, there was again a trend towards improved overall survival. So what this tells us is not only does it improve progression-free survival, using these more effective therapy earlier can also help us improve overall survival of patients with myeloma, likely because when they progress later, they may not even have the opportunity to get CAR-T. So the second CAR-T that got approved in the United States and then subsequently in many countries in the world is cilta-cel, ciltacaptogene autoleucel, also called Carvykti. This also targets BCMA, but the CAR-T constructs are very different. Abecma has a single chain variable fragment with a heavy chain and light chain. This has 2 heavy chains. It's derived from llama. Abecma is derived from a murine antibody, and so they look very different. And it also binds, in my opinion, more tightly to BCMA. Again, this was approved on a phase 2 clinical trial called CARTITUDE-1, which included very heavily pretreated patients with median of 6 prior lines of therapy. Most of these patients were triple-class refractory. And here, the response rate was 98%. We had never seen that before. The complete response rate was over 80%. Again, never seen that before. And the median progression-free survival was almost 3 years, compared to the historical of 3 to 6 months. So this really, again, was a significant step in the right direction for patients with relapsed refractory myeloma. It was but natural to think what happens when you use this earlier in treatment line. So CARTITUDE-4 clinical trial was designed to test this in early treatment line, 1 to 3 prior lines of therapy in Len refractory patients. Now, they were randomized 1:1 to either get cilta-cel, Carvykti, or standard of care treatment, which was either daratumumab, pomalidomide dexamethasone, or pomalidomide bortezomib dexamethasone. And as shown here, this was a New England Journal of Medicine publication last year. Patients who got cilta-cel had a significantly better progression-free survival than those who got standard of care. Standard of care PFS was 1 year, which is what we would expect with this regimen. The median has not yet been reached in this trial. No crossover was allowed, and we will see overall survival data presented in 2 weeks at the International Myeloma Society annual meeting in Rio, which, if we look at the FDA hearings from this, seems to be going in the right direction, but I think that is something very interesting that will come out in 2 weeks. Now, based on this data, cilta-cel was FDA approved in the United States after 1 prior line of therapy in April of this year. Doesn't mean that we are using it after 1 prior line of therapy in all patients, but it is an option for earlier line use. So I showed you great data about clinical trials, but clinical trials are done in ideal setting with the perfect patient, especially for CAR-T with very stringent eligibility criteria. And this is where real-world data comes in. Because does that data apply to your patient that you're sitting in front of you who may not be as fit to be eligible for the clinical trial? So real-world data can really provide safety and efficacy data in a broad patient population in a short period of time. We can also study populations of special interest that were excluded from clinical trials, such as renal failure patients, patients who did not get the typical lymphodepletion that you get before CAR-T. We can find out data on less common adverse events and optimal management of those. And it potentially might apply for comparison of different CAR-T products. We don't know which one is better, Abecma or Carvykti, ide-cel or cilta-cel, but in some non-perfect way, this data can be used to compare those because such clinical trials are unlikely to be performed. So this was my privilege to present data from the CIBMTR registry on 800 patients treated with ide-cel at ASH meeting last year. And these patients were treated with standard of care ide-cel, followed for over 1 year after infusion. And so on the left-hand side is baseline characteristics of patients treated with standard of care ide-cel, on the right-hand side on the trial. I will not go through each one of those, but this was a very heavily pretreated population of median of 7 prior lines of therapy, very similar to the KarMMa trial of 6 prior lines of therapy. 18% of them had had prior BCMA-directed therapy, which was, of course, not allowed in the clinical trial, most commonly belantamab mafodotin, which is an antibody-drug conjugate. 27% of these patients had high-risk cytogenetics, 17% had extramedullary disease. So again, just to emphasize that this was a heavily pretreated population. But what is very important is that 77%, over 3/4 of these patients, had comorbidities that would have made them, many of which would have made them ineligible for the clinical trial for KarMMa. So let's see what happens in this heavily treated population that are not as fit patients. And what you see here is that the toxicity profile for cytokine release syndrome and ICANS, or immune cell-associated neurotoxicity syndrome, is very similar in the real-world evidence in the CIBMTR study. Also, I co-lead a US consortium on CAR-T, which also had very similar results in 160 patients compared to the KarMMa trial. And even though these patients are not as fit or robust in terms of comorbidities, the response rates are very similar to the KarMMa trial at about 70 to 80% with real-world data. And the progression-free survival is virtually identical, 8.8 to 9 months. So despite most patients in the real world that we see in our clinic not being as fit in terms of comorbidities or performance status as clinical trial patients, these therapies can be used safely and effectively in patients we routinely see in the clinic. We also looked at what happens if patients got prior BCMA therapy. And because the target is the same, we saw that these patients have lower response rate and inferior progression-free survival compared to patients who did not have prior BCMA therapy. So again, I had the privilege of presenting this data on behalf of the US Multiple Myeloma CAR-T Consortium at the IMS meeting last year, looking now at real-world data with cilta-cel. And this is over 160 patients who underwent collection to manufacture cilta-cel. 151 were infused. Now, this median follow-up was 6.9 months. We will be updating this data in 2 weeks at the IMS meeting with 255 patients and 1 year of follow-up, but I'm not able to share that right now since it's embargoed. And here, too, Most of the patients were very heavily pretreated, median of 6 prior lines of therapy, just like the trial patients. A third of patients were pentadrug refractory. 40% of patients had high-risk cytogenetics. So again, a very heavily pretreated population. And yet, over half of these patients that got standard of care CAR-T would never have met the eligibility criteria for CARTITUDE-1, mainly because of low blood counts, organ impairment, or poor performance status. And yet, these patients seem to do quite well in terms of effectiveness of CAR-T. So when you look at all of these patients, all 151 patients who actually got the CAR-T, the response rate was 87%. When you narrow it down to a group that actually got a conforming product, so there are some release criteria that you have to have certain dose, certain viability of the CAR-T to call it conforming, and patients who don't have a conforming product can be treated on an out-of-spec protocol. But when you look at the real stringent criteria, these patients had a much higher response rate of 95%. The follow-up is short. The median has not yet been reached for progression-free survival, but looks very encouraging. So what about safety of this agent in patients who may not be as fit? Again, the safety was very comparable to clinical trial patients in terms of cytokine release syndrome, including severe cytokine release syndrome. So grade 3 or higher cytokine release syndrome is when patients get hypotensive, requiring pressors in the ICU. And thankfully, that's seen in only 5% of patients with cilta-cel or even with ide-cel. ICANS was seen in about less than 20% of patients, usually grade 1 or 2. Now, delayed neurotoxicity is a unique challenge that's most commonly seen with cilta-cel. I'll touch upon it in the next few slides. And this encompasses anything from cranial nerve palsies to Parkinsonism. And that was also similar in the real-world data as in the clinical trial, about 10 to 12%. Non-relapse mortality in the real world is significant at 10% compared to 6% in the clinical trial, most commonly due to infections, highlighting that these patients need aggressive supportive care, including prophylactic antibiotics, intravenous immunoglobulin, and so on. So again, as I said, in 2 weeks, we'll be able to share more updated data with 1 year of follow-up, but what I can share is the data looks really promising. So what about, this is great, the data that we have is great, but what are the unmet needs of CAR T-cell therapy in myeloma? I think the first is patient selection. As I showed you, the clinical trials cherry-pick the best of the best patients, but our patients in the clinic have other comorbidities, kidney impairment, heart disease, and so on, and they would never be fit for clinical trials. But what we saw was that these patients can also, at least when they were judged by their treating physician to be fit for CAR-T, have good outcomes with CAR-T. But there's a lot of logistical challenges. One, it's a very complex process to manufacture CAR-T. It can take anywhere from 3 to 8 weeks, right? So manufacturing availability is also limited. Even in the United States, even after we had approval, we could only, in the beginning, get 1 or 2 slots a month. That created a big challenge for access and ethical issues as to who should get those slots. And thankfully, that is getting better. But we still need access across the whole world. Access here in Poland, access across in other countries of the world. So that's a challenge. Now, these therapies can only be given at very select centers, just like allogeneic transplants. So patients have to travel to different centers and often have to relocate with their family. And of course, prior treatment consideration. Alkylators like bendamustine, when given before CAR-T, especially within 6 months, they kill the lymphocytes, don't lead to successful manufacture. Or other BCMA-targeted therapies or bispecifics that can lead to T-cell exhaustion. So a lot of logistical considerations. So again, patients with multiple myeloma are prone to have renal impairment. In fact, renal impairment is a hallmark feature of myeloma seen in about 1/4 of patients. Yet these patients were not studied in clinical trials. What we found with our US Multiple Myeloma Consortium database is that patients with renal impairment can do just as well with CAR-T in terms of effectiveness of CAR-T. They do have a little more cytopenias and longer duration of hospitalization, but other side effects with ide-cel CAR-T are very similar. So they should not be excluded from getting CAR-T when we see these patients in the real world. Then coming to an area of unmet need, which is evolving, is management of delayed toxicities. So toxicities with CAR-T in myeloma can be early in the first few days and weeks, which primarily includes cytokine release syndrome, which is most commonly just fever, but in severe cases, hypotension and organ failure. Neurotoxicity, which is coined as ICANS, immune effector cell-associated neurotoxicity syndrome, which manifests from delirium to confusion to obtentation. Hemophagocytosis-like syndrome. Again, these usually happen in the first couple of weeks. Cytopenias and infections patients can be at risk throughout, mostly in the first few months, and then the risk decreases. But what is challenging, we've gotten used to managing these toxicities. But what is challenging us is now delayed or unusual toxicities like delayed neurotoxicity, particularly that we see with cilta-cel, and then long-term toxicities like second primary malignancies, other unknown late side effects. We are just getting to understand who is at risk of second primary malignancies, how do we follow them, can we identify certain patients who shouldn't get CAR-T? I think these are all unknown questions at this point. So focusing on delayed neurotoxicity, predominantly seen with cilta-cel, all the cases have been described with ide-cel and other CAR-Ts. Not yet reported with bispecific antibodies, even though they target the same, but perhaps it's just the penetration into neurons and brain tissue that's a challenge here. It is a heterogeneous group. It varies from Parkinson's-like syndrome to cranial nerve palsies, peripheral neuropathy, etc. Again, seen in 10 to 12% of patients. Parkinsonism was seen in 6% of patients in the initial trial and really had us worried. But thankfully, in the earlier line trial with CARTITUDE-4, only seen in less than 1% of patients. In the real-world data, we are so far only seeing in 2% of patients, even with 1-year follow-up. But again, when it happens, it's devastating. Cranial nerve palsies, it's very unusual. What happens, it's mostly seventh nerve palsy, almost like a patient got a stroke. One of the first patients I had this was not well known then. It's like, did this patient have a stroke? I sent that patient to the emergency room, they did an MRI, everything's fine. And then later from, ruling out other causes, we realized this must be CAR-T toxicity, and then we started hearing about more cases. We don't know why seventh nerve. Sometimes ocular nerves can also be involved, but it's mostly the facial nerve that's involved. And again, we have to consider brain imaging and in some cases a lumbar puncture to rule out other etiologies such as infections or disease relapse, but most commonly that's not the case. And median time to onset is 3 to 4 weeks. Again, it can take a very long time to recover. It usually recovers, takes several weeks. The treatment that we understand today is low-dose steroids for a short duration of time, and then the recovery will happen over several weeks. But again, we don't understand why it happens. We know that patients who have higher CAR-T expansion are at higher risk, but why seventh nerve? What's the mechanism? Nobody knows. So Parkinsonism, and this can vary. It can vary like a tremor with Parkinson's, or more commonly we're understanding these are subtle personality changes that patients can also have. We as physicians may not even appreciate that, but the family member says, my husband or wife has a flat affect. They're not the same person as they were before CAR-T. So it really takes a lot of partnership with your neurologist to sometimes understand these subtle symptoms, which we are beginning to understand. Risk factors, we know that having high tumor burden before going into CAR-T is a risk factor. Getting severe CRS or ICANS that's not managed quickly and high CAR-T expansion is a risk factor. And we're just beginning to understand the mechanism of that. So this is a case report of one patient who got Parkinsonism 3 months after CARVYKTI, cilta-cel. And the CAR-Ts were found in the cerebrospinal fluid. Unfortunately, this patient did not respond to any treatment, including Parkinsonism treatment, and patient died. So in autopsy, they found a lymphocytic infiltrate in the basal ganglia, which is the area where Parkinson's happened, saying that CAR-T cells were being trafficked there. And they also found that BCMA was expressed there at low level. So perhaps the mechanism is that this is a very strongly binding CAR-T, BCMA is expressed at low levels, and somehow the CAR-T cells in some patients infiltrate there and bind and cause irreversible damage. Again, this is just very early data, and in the coming years, I think we'll learn more about why this happens, how we treat it. So typically, the Parkinson treatment doesn't work. Levodopa, carbidopa, and other drugs don't really cause improvement. But there is this case report that was published in Blood last year of using chemotherapy. Because this is CAR-T cell driven, so using chemotherapy, cyclophosphamide in this case, to bring down the CAR-T cell levels caused an improvement in symptoms. And I can tell you I have now used it in several patients, 2 or 3 of my personal patients, and at least 2 of those patients responded to cyclophosphamide when given early. When you see CAR T expansion, the symptoms improved. In fact, one patient had symptoms 2 weeks after CAR T. We gave them 1 gram of cyclophosphamide. The next day, the tremor went away. 2 days later, it came back. We gave another gram, and the tremor went away. But then, that patient got aspergillus pneumonia, so you have to be very cautious with infections when you are giving high-dose chemotherapy. But this might be one way of mitigating the side effect when it develops. So CAR T has led to really deep and durable responses, but unlike some of the CAR Ts for lymphoma, we are not yet seeing cures in myeloma. So relapse is a new unmet need. Now, antigen escape or loss of BCMA is not very common. It's seen in about 5% or fewer patients after CAR T. So we still don't understand why most of the patients relapse. Is it T-cell exhaustion with CAR T still being there? Is it lack of T-cell persistence? And then when we try to reinfuse the same CAR, that doesn't work, probably due to anti-CAR antibodies that the patients develop. Again, these are not human-derived CARs. They are either mouse-derived or llama-derived. So it's very quick that our bodies develop immune responses to these CARs. So when you reinfuse, it doesn't work. Now, we also need to understand with bispecific antibodies being there, with ADCs being there, what's the right way to sequence these therapies? Do we do CAR T first? Do we do ADCs first? And then, of course, other non-BCMA targeted approaches in development. So I'll just spend a couple of minutes talking about sequencing. So CARTITUDE-2 was a small study in which they looked at cilta-cel after prior BCMA bispecific or antibody-drug conjugate therapy. This was 20 patients, and unlike the 90-some% responses you saw in BCMA-naive patients, here the response rate was only 60%. The median progression-free survival was only 9 months compared to the 3 years. So clearly, when you use CAR T after prior BCMA-directed therapy, it doesn't work as well. In fact, patients who got BCMA bispecific antibodies only had a PFS of 5 months. And I think it's also not just antigen, BCMA, but also T-cell exhaustion that contributes to that. We also looked at this in real-world data with ide-cel, and the same thing played out. Prior BCMA therapy was associated with lower response rate to ide-cel. Specifically, prior bispecifics, even though the numbers are very small, those patients had the worst progression-free survival. So not only just related to the BCMA antigen, but also probably to do with T-cell exhaustion. On the other hand, this data is just emerging, but when you use CAR T first and then you use bispecific antibodies later, the response rates are maintained. We still don't know much about progression-free survival, but the response rates are just as high as what is seen in BCMA-naive patients. And what's very interesting is with talquetamab. Dr. Wiesław will talk about bispecifics, but talquetamab is a GPRC5D targeting antibody. So BCMA doesn't play a role here. But when you see, if you got prior CAR T, the response rate with talquetamab is 75%. But if you got a prior bispecific antibody, the response rate is only 44%. It's not just about antigen, it's also about T-cell exhaustion and T-cell health. So this is my sequencing approach if CAR T is available, which I know that is not an option in many countries right now. But if someone's a CAR T candidate and they can wait for manufacturing and a slot to be available, I prefer to use CAR T first, just because you can use bispecifics very successfully after. Of course, if a CAR T is not available or someone cannot wait for CAR T or is not a candidate for CAR T for other reasons, then I go with bispecific antibodies. And there's, of course, BCMA targeting one and GPRC5D targeting one. I won't go into detail, as Dr. Wiesław will talk about, but their toxicity profile is different, so that's how I choose based on toxicity profile. There are new targets in development. We have GPRC5D, we have FCRH5, we have dual targeting CARs that are now in development. I'll just talk about GPRC5D, which is a unique target that's present on plasma cells, but also present in skin, hair follicles, and tongue, and that plays a role into toxicity. And so this is early data with the phase 2 clinical trial of GPRC5D-directed CAR T. And here you can see the response rates were very high, almost 90%, including in patients who had prior BCMA therapy. The median progression-free survival has not yet been reached, but with a median follow-up of about a year, about 2/3 of patients were still in remission. So with that, I'll summarize that BCMA CAR-T therapy is now available as standard of care for multiple myeloma in several countries, although access remains a challenge in other countries, and I hope will be available soon in other countries as well. But majority of patients, at least in the United States, are not fit or robust or eligible for trials, yet they do very well with CAR-T cell therapy. Delayed and unusual toxicities, including neurotoxicities and second cancers, are seen, and they will remain an issue that we need to learn how to manage better. And early data, if both are available, suggests that we can use CAR-T before bispecifics for optimal efficacy when both are available. And newer CAR-T targets like GPRC5D are in development. With that, thank you very much for your attention. It's been a true pleasure.
Thank you very much. Before I will ask for questions from you, I will ask, are there any data concerning comparison of CAR-T therapy to transplantation?
Yeah, that's a great question. So we don't have any data right now comparing CAR-T to transplantation, but a clinical trial is open both in Europe and United States called CARTITUDE-6 that randomizes patients after induction therapy for newly diagnosed myeloma with a quadruplet to either getting a transplant, an autotransplant, or cilta-cel. I'm sure those results will take several years to mature, but those trials are ongoing. Yeah. But we don't have any data.
Another question is, it appears from what I have heard, is that cilta-cel is better than ida-cel. Can you have some sort of clue what is the what are the difference between the two preparations that may be responsible for this difference?
Yeah. Yes. So as I alluded to a little bit, even though both of them target BCMA, the construct looks very different. Cilta-cel has 2 heavy chain epitopes and apparently binds very tightly, and it's derived from a LAMA antibody. Ida-cel has a single chain variable fragment with a heavy chain and light chain. The response rates in the trials, of course, look very different, with progression-free survival of 9 months with ida-cel, almost 3 years with cilta-cel. And perhaps it has to do something with the strength of the binding, because the dose for cilta-cel is also lower than the dose for ida-cel. But the expansion is there, and it's not like it lasts longer in the body. After 6 months, you really can't find cilta-cel in most of the patients circulating. So I think it has to do with the heavy binding. At least on cross-trial comparisons, it looks that it is more potent. But it also has more side effects, such as with the delayed neurotoxicity, perhaps because of the same reasons, with more potent binding. I can share that at the IMS meeting in Rio, we will be presenting data where we compared ida-cel to cilta-cel in real world. Now, it's very hard to compare across trial, but what we did is we tried to match the patients who got ida-cel and cilta-cel, and what we would think is happening, that cilta-cel has a higher response rate, but also has a higher toxicity profile.
Thank you very much. Professor Skotnicki.
It's really, my voice is better than CAR-T cells, so I'll do my best. For many years, we have been thinking about myeloma as a very good target for immunotherapy intervention, starting from our knowledge that from pre-myeloma situation, development to open myeloma is going together or simultaneously with decrease of T-cell dependent immunity. I hope you agree. Afterwards, immunomodulatory therapy were effective. And many years ago, a distinguished Swedish hematologist, Gösta Garton, who visited this place many times, was very fond of allogeneic stem cell transplantation in relapsed multiple myeloma patient. Of course, we know effectiveness was due to T-cell dependent graft material. Afterwards, it was found out it's a very toxic procedure. But anyway, do you think to some extent CAR-T cell therapy is continuation of this idea of using T-cell now directed specifically against multiple myeloma? So the previous graft versus myeloma effect, now this idea is developing in this way, and whether it is less toxic than allogeneic stem cell transplantation, which toxicity was mainly due to infection complications.
So thank you for that, very, very insightful comment and question. I 100% agree with you that T-cell health really impacts the efficacy of immunotherapy, and these therapies are just harnessing that. Of course, with CAR T-cell compared to allotransplant, you don't need HLA dependence, so that is easier. It's autologous, so it's easier. In terms of toxicity, of course, you don't see graft versus host disease, but we don't know what other long-term complications are in terms of second cancers. So when you look at mortality, with allogeneic transplant, mortality was 15% or higher. Here, mortality is 5 to 10%, but that's not trivial. Again, these are very heavily pretreated patients, so hopefully as you move it earlier line, mortality will go down. What's very interesting is that now with allogeneic transplant, with graft manipulation, mortality is now decreasing to 5 to 7%. So that's my colleagues at Stanford University are doing clinical trials with graft manipulation, sorting cells, and they are seeing less, toxicity and less mortality. So maybe it'll make a comeback for myeloma, although we did not see so much graft versus, tumor effect for myeloma. So I think overall, of course, mortality is much lower with CAR T than we historically saw for allogeneic transplant. But there's a long way to go to decrease mortality even for CAR T. Yeah.
Thank you very much. Professor Sacha.
Thank you for a wonderful lecture.
Put the microphone. Tomek.
I want to ask you about the Parkinson's disease, how frequent it is. And regarding that, the cyclophosphamide is a very interesting drug, which action depends on the doses. So what kind of doses are used in those patients, and what are the immunomodulatory effect of those doses?
So, Parkinson's in the first clinical trial, CARTITUDE-1, of course, there were some initial trials in China when this was still being developed in China. There was no reports of Parkinson's disease seen there, whether it was just by chance or, we don't know that they didn't catch that this might be related. But in the trial that was run in the US, we saw 6%, which was very high risk. And then they understood that, if you go in with high tumor burden, that increases risk. So for the next trials, they started doing more bridging therapy to suppress the tumor burden. And then the risk was in CARTITUDE-4 less than 1%. In the real world today, with good bridging, we have 2%. So it's not everybody, but still when that happened, it's devastating. So with cyclophosphamide, the dose needs to be high, at least what we're seeing anecdotally. No one studied different doses, but the dose used in the blood paper was 2 grams per meter square, and that's the dose we've been using in clinic. Of course, with that dose, infection becomes a huge issue. These people are already immunocompromised, no B cells. On top of that, we're giving Cytoxin, killing even the healthy lymphocytes. That's a challenge. So till we get better therapies, that's what we have, but it's high doses of Cytoxin. Yeah.
Thank you very much.
Yeah.
I've got a question. Thank you for the great speech. CAR T-cells bring hope for the refractory relapsed multiple myeloma patient, but I've got, I wonder, do you have any experience with intestinal microbiome and CAR T-cell?
So I personally don't for multiple myeloma CAR T therapy, but my colleague, Dr. Melody Smith, she does laboratory research, and with CD19 CAR T, which is in lymphoma, they found that when you use broad-spectrum antibiotics, that kills the intestinal microbiome. Those patients do worse compared to when you use narrow-spectrum antibiotics, where the microbiome is still preserved, even in terms of effectiveness of CAR T. Now, why that happens, I don't understand, and we don't have any data in myeloma, but specifically in CD19 CAR T, it's probably better to use narrow-spectrum antibiotics and have a healthy microbiome. Yeah.
Thank you.
Thank you.
Thank you very much for the lecture. Talking about CAR T cells, if you have a young patient whom you just diagnosed with myeloma at this point, would you consider collecting and preserving T cells together with the stem cells for later use? Or this is, and if yes, at what point of the disease course would you do that?
I think that's also a million-dollar question, which we're all, trying to answer. But practically speaking, there is no way to collect lymphocytes and store them because all of the manufacturing for CAR T is from lymphocytes that are just collected. So at least in the US, the FDA regulates it, right? So if we stored something today and we send to a company 2 years later, they won't even use right now with the current regulations to manufacture them. Having said that, this is such a new field that I can see this happening, any day in clinical trials, and we should be able to do that in the future because these cells are technically healthier than when they're very late relapse. It's just that we don't have the data or the regulatory approval to be able to do that right now, or who's going to pay for storage indefinitely, that's also a challenge. But I think that's a great question. Now, when we do that, I don't know. Do we do it when their tumor burden is newly diagnosed, high tumor burden, or you debulk them and you're just maybe, before they get their auto transplant, the first collection you do is, apheresis to collect their lymphocytes, and the second, then you do GCSF and do their auto transplant collections. I think that's the wave of the future, but we just don't have any data quite yet.
You should continue the next lecture.
Okay, just last question, Surbhi. Wonderful talk as usual. You didn't talk too much about post-cellular therapy cytopenias and the role for stem cell boost. Yeah. When do you do it? How much stem cells do you really require? Do you need to wait for 30 days, wait for 2 months? Yeah.
So I think that's a great question. I didn't talk because I only had 20 minutes. I can talk about this topic for hours. But so we see in real-world data about 5% of patients have severe cytopenias that require a stem cell boost. And usually after stem cell boost, recovery of counts is good. My anecdotal experience is that if someone wait at least 2 months, because many people recover by themselves by 2 months, and if they don't have any active inflammation, that's a good time to do it. I have personally had 2 anecdotal cases where we gave, someone had HLH, they had very bad counts, bad infections. We thought, we have stem cells stored, we'll give it to them. And we are, in the process of publishing this data is they recovered their counts beautifully, but then their HLH had already gone down and it came up. Now, whether it is because of cytokines that were brewing at the time of engraftment, whether it's coincidence, but we had 2 patients who actually died after that. So our policy is we can do it, but not in setting of active inflammation, and we probably wait about 2 months. Now most places will also wait about at least 2 months or 45 days to do that, talking to colleagues. But yeah, very important question. And cytopenias are very unpredictable. They recover, they go down, it's like up and down. So it's not like transplant, they go down and come up, yeah. So, great, thank you.
Thank you very much.
Thank you very much.
A very interesting lecture. Thank you very much. The second lecture will be pronounced by Professor VAISHALI SANCHOROWALA from Boston Medical Center, United States. The lecture is titled Advance in Systemic HL Amyloidosis. Professor, please start.
So good afternoon, everyone. I'm VAISHALI SANCHOROWALA, and with deep gratitude and thanks to Professor Arthur Jurczyzyn, I present to you the advances in systemic AL amyloidosis. It's my first time in Poland, and it is absolutely a phenomenal country with a long, long, long history. So thank you very much for inviting me and including this rare zebra in this complex plasma cell dyscrasia treatment. So these are my disclosures. And this is the outline of my talk. We will begin with patient journey in this rare disease of AL amyloidosis. The path to diagnosis of AL amyloidosis can be quite rocky and complex because it is a rare disease with an incidence of 1.2 cases per 100,000 person years. Amyloidosis Research Consortium is a patient-led organization that conducted a social media survey of 500 patients and caregivers suffering from amyloidosis in 2015. And this survey report showed that time from initial symptoms to diagnosis of amyloidosis was greater than 12 months in 40% of the patients. Moreover, number of physician visits before an established diagnosis of amyloidosis was greater than 2 in 60% of the patients. And to our surprise, the diagnosis of amyloidosis was correctly obtained by primary care physicians who are supposedly the gatekeeper of healthcare system in only 4% of the patients. This particular survey indicates significant delays and multiple physician visits before a diagnosis of amyloidosis is made. What have we learned and what is so different in 2024? In 2022, Amyloidosis Research Consortium performed a larger community survey in greater than 1,200 patients and caregivers across the globe. And what did they find? The average MDs seen before accurate diagnosis of AL amyloidosis was 3, and the most common barriers to diagnosis were misdiagnosis, inability to obtain specialists, and inability of getting testing performed. Similar stories exist across the globe. In France, 603 patients with systemic amyloidosis performed this survey, and it was noted that average time from symptom onset to diagnosis of AL amyloidosis was close to 2 years. Early diagnosis remains the cornerstone for improving outcomes of patients with AL amyloidosis, and a potential path to earlier diagnosis of AL amyloidosis in subset of patients with smoldering myeloma and monoclonal gammopathy of unknown significance could be an assay to rapidly screen for immunoglobulin light chain and glycosylation by mass spectrometry-based techniques. The kappa light chain immunoglobulins can have and glycosylation as predictive tool for AL amyloidosis. Unfortunately, only 20% of patients with AL amyloidosis have kappa clonal plasma cell dyscrasia, and 80% have lambda clonal plasma cell dyscrasia. Artificial intelligence has also made its path in early diagnosis of patients with AL amyloidosis. This is a Mayo Clinic study of patients with cardiac involvement and cardiac amyloidosis and pre-diagnosis ECG studies. The AI model was successfully able to predict the presence of cardiac involvement more than 6 months before the clinical diagnosis in 60% of the patients. Pathogenesis of AL amyloidosis begins from a small, dangerous B-cell clone in the bone marrow that produces kinetically or thermodynamically unstable light chains which interact with cellular and extracellular matrix protein and extracellular chaperones to form soluble oligomers. These soluble oligomers then interact with serum amyloid P protein and glycosaminoglycans to form amyloid fibril deposits. The mechanisms of organ dysfunction are twofold. The first is deposition of amyloid fibrils in the organs, disrupting the architecture of the organs, leading to organ dysfunction. And or the next mechanism is the direct proteotoxicity of soluble precursor proteins and soluble oligomers, leading to organ dysfunction. The latter mechanism of action has been studied in C. elegans and zebrafish models where cardiac contractility and relaxation were impaired where human amyloidogenic light chains were injected to these animals. Camille Edwards, from one of our junior faculty from Boston University Amyloidosis Center, has been performing experiments mapping the molecular mechanisms that drive amyloidogenic light chain-induced cardiac toxicity in patient-specific induced pluripotent stem cell-derived cardiac myocytes. The conclusions of our experiments are that there is upregulation of transcripts associated with cardiac hypertrophy and cardiac remodeling, and downregulation of transcripts associated with adaptive immune response. The diagnosis of AL amyloidosis requires 2 steps. The first step is demonstration of congophilic material in the tissue diagnosis that is subjected to Congo red staining and examined under polarized light microscopy that shows apple green birefringence. In systemic AL amyloidosis, surrogate site biopsies like abdominal fat pad aspiration, bone marrow biopsy, and minor salivary gland biopsy can demonstrate congophilia in 70 to 80% of cases. If clinical index of suspicion is high and the surrogate site biopsy do not show congophilia, target organ biopsy of the kidneys or heart must be performed. Once tissue diagnosis is confirmed, it is absolutely crucial to unequivocally identify the amyloidogenic precursor protein. And there are different techniques that can be used to type the amyloid precursor protein, either by immunohistochemistry, which unfortunately is unreliable in 2/3 of patients with AL amyloidosis with commercially available antibodies. We at Boston University perform immunogold electron microscopy with gold label antibodies, which has the specificity of accurately diagnosing amyloid precursor protein in 99% of cases, even with commercially available antibodies. Now, mass spectrometry-based techniques to identify accurately amyloid precursor protein remains the gold standard and is not antibody dependent. Plasma cell clone in AL amyloidosis is very small, with a median number of cells being 10%, and in 20% of cases, this plasma cell clone is less than 5%. The last row of this table demonstrates the diagnostic sensitivity of serum and urine immunofixation electrophoresis and serum-free light chain ratio in identifying this monoclonal protein in 98% of the cases. Novel mass spectrometry-based techniques may increase the diagnostic sensitivity of identifying this small plasma cell clone. This slide demonstrates the levels of detection of novel mass spectrometry-based techniques of MassFix and MyRAM that have the levels of detection of 0.005 grams per liter and 0.001 grams per liter for the monoclonal protein detection. The plasma cell clone in AL amyloidosis is different than in multiple myeloma, not just by the size of it, but also the transcriptomic profile of plasma cells in AL amyloidosis is similar to that in normal plasma cells, and immunophenotypically, these plasma cells are difficult to be differentiated from those in multiple myeloma. Cyclin D1 is a more prominent driver in AL amyloidosis than in multiple myeloma, and translocation 1114 is present in almost half of the patients with AL amyloidosis compared to 1/4 of patients with myeloma. Cardiac involvement remains the driver for overall survival in patients with systemic AL amyloidosis. In 2004, almost 2 decades ago now, the Mayo Clinic investigators developed a risk-stratifying staging system incorporating cardiac biomarkers of NT-proBNP and troponin T. They were able to discriminate patients into 3 stages, predicting for overall survival. European investigators then updated this staging system and modified it by incorporating NT-proBNP levels of greater than 8,500 picograms per ml, predicting for overall survival of less than 6 months. Mayo Clinic investigators updated this staging system in 2012 to incorporate markers of plasma cell dyscrasia, difference between involved and uninvolved light chains, along with the cardiac biomarkers, discriminating patients into 4 stages, again predicting for overall survival. As shown here, the median survival does remain less than 6 months for patients with advanced cardiac involvement. At Boston University, we developed a staging system incorporating readily available cardiac biomarkers of brain natriuretic peptide and troponin I, discriminating patients again into 4 stages, predicting for overall survival. UK National Amyloidosis Center compared Mayo 2004 to Mayo 2012 staging system in a uniformly treated 1,200 patients with AL amyloidosis who were treated with bortezomib-based therapy. The median overall survival in stage 4 patients, that is Mayo 2012, is 26 months, and stage 3B patients is 7 months. Now, they also noted that the median overall survival ranged from 5 months to 74 months for Mayo 2012 stage 4 patients. The conclusion of this paper is that Mayo 2004 staging system with European modification is better in predicting overall survival as well as early mortality, particularly in the days of contemporary, more effective plasma cell clone-directed therapy. As multiple times I've stated, cardiac involvement remains the driver for overall survival. Transthoracic echocardiography is the cornerstone for diagnosing cardiac involvement in patients with AL amyloidosis. There have been several novel techniques, imaging modalities that have been developed recently to identify cardiac involvement earlier in the course of the disease. One of them is echo with strain Doppler imaging, cardiac MRI with T1 mapping and expansion of extracellular volume, and 18F floor beta pair PET scan imaging showing cardiac involvement earlier in the course of the disease. Word on bone scintigraphy, which is a non-invasive diagnostic test for ATTR amyloidosis, is not positive in patients with AL amyloidosis. International Society of Amyloidosis have unified hematologic and organ response criteria after treatment for patients with AL amyloidosis. Several groups across the globe have refined the hematologic response criteria by incorporating low serum free light chain endpoints and DFLC of less than 10 milligrams per liter and IFLC, involved free light chains, of less than 20 milligrams per liter can predict for better overall survival, even in those who have achieved a complete hematologic response based on conventional response criteria. Measurable residual disease assessment by multiparametric flow cytometry can predict for better organ response rates as well as for major organ deterioration progression-free survival. Measurable residual disease assessment by free light chain mass spectrometry can detect persistent light chains in 60% of patients with a conventional hematologic complete response at 12 months following treatment. Patients with non-detectable FLC by FLC mass spectrometry have significantly overall better overall survival and organ response irrespective of conventional hematologic response. We now, with an international collaborative effort, have updated organ response criteria, and now we have graded them, again showing overall survival predictability of graded cardiac response criteria at landmark analysis of 2 years following treatment. A longitudinal natural history study of 40 years in systemic AL amyloidosis from Boston University Amyloidosis Center of 2,500 patients have shown a dramatic improvement in overall survival with a median overall survival of 1.4 years in the mid-1980s to 4.6 years in the mid-2010. This is attributable to the expanding therapeutic landscape of AL amyloidosis. Most of these treatment regimens are borrowed and adopted from those in multiple myeloma. High-dose melphalan, an autologous stem cell transplantation, was initially performed in AL amyloidosis in the mid-1990s. Since then, we at Boston University Amyloidosis Center have treated 650 patients, consecutive patients, who have undergone treatment with stem cell transplantation, showing a median overall survival of 7.6 years with a 10-year projected survival of 67% in the most contemporary era. International Society of Amyloidosis and EHA working group have published guidelines for high-dose chemotherapy and stem cell transplantation in AL amyloidosis with respect to eligibility criteria, with respect to conditioning regimens, respect to mobilization regimens, and the best post-transplant supportive care, which was published in 2022. Unfortunately, only 20% of patients with newly diagnosed AL amyloidosis are eligible to receive stem cell transplantation, either because of poor performance status or because of advanced heart and renal involvement. Andromeda clinical trial led to approval of non-stem cell transplant regimen daratumumab plus bortezomib cyclophosphamide dexamethasone or VCD in the treatment of AL amyloidosis. Andromeda clinical trial was a randomized global phase 3 clinical trial of patients treated with VCD plus daratumumab versus VCD alone in newly diagnosed AL amyloidosis. Hematologic complete response rates were significantly higher for those who were treated with VCD plus daratumumab, ranging to 60% compared to 19% for those who were treated with VCD alone. Organ response rates were also significantly higher for those who were treated with Dara VCD compared to VCD alone, and it ranged from 53 to 58% respectively in cardiac and renal responses. Again, EHA and ISA working group have published guidelines for non-transplant chemotherapy regimens for treatment of AL amyloidosis, and I refer you to this paper published in 2023. As we have heard, daratumumab, a monoclonal anti-CD38 antibody, has been a game changer in patients with AL amyloidosis. This slide shows you an aggregate of all studies when patients with AL amyloidosis are treated with daratumumab, either in previously untreated patients or in patients who have relapsed AL amyloidosis. Again, the hematologic response rates with this agent are unprecedentedly high, with overall hematologic response rates of 80 to 90% and complete hematologic response rates of 40 to 50%. As stated earlier, 50% of patients with AL amyloidosis harbor translocation 1114. Venetoclax, a small molecule against BCL2 inhibition, can be utilized in patients with AL amyloidosis. This is a retrospective, multi-center, international collaborative effort showing a response rate, a hematologic response rate of VGPR and CR in 78% of patients with relapsed refractory AL amyloidosis who harbored translocation 1114. We must, however, look beyond the plasma cells in this complex AL amyloidosis. We should combine therapies that lead to suppression of amyloidogenic precursor protein secretion, stabilize the misfolded amyloid precursor protein, and finally offer antibodies, drugs that can clear the amyloid deposits from the organs. We at Boston University are developing a small molecule as a light chain stabilizer for treatment of AL amyloidosis. Two antifibril agents that are utilized and are being studied in clinical trials are birtamimab and KLM-101. Birtamimab is a monoclonal antibody that was studied in phase 3 VITAL study of birtamimab versus placebo plus standard of care plasma cell dyscrasia directed therapy in patients with newly diagnosed AL amyloidosis. This trial, unfortunately, was discontinued for futility analysis. However, on an unplanned post-hoc analysis, 9-month all-cause mortality, quality of life, and functional capacity were in favor of birtamimab plus standard of care treatment regimen for Mayo 2012 stage 4 patients. This molecule is undergoing clinical trials at this current time globally as AFFIRM-AL trial. KLM-101 has already undergone clinical trials, phase 3 clinical trials in stage 3A and 3B, Mayo 2004 AL amyloidosis, and we are awaiting a final analysis of this molecule. In this phase 1B open label study, KLM-101 led to therapeutic response by biomarkers as well as by objective imaging modalities of a GLS. Integrated care at specialized centers helps patients and physicians navigate the challenges of this rare disease, and this is the multidisciplinary care model that we utilize at Boston University Amyloidosis Center. The future directions in systemic AL amyloidosis should focus on improving early diagnosis, defining standards of care for advanced cardiac stage patients, validating a definition of hematologic progression, evaluating new sensitive techniques to assess hematologic response, and to perform clinical trials of novel clone-directed therapies with alternative treatment targets. With that, I would like to acknowledge many members of my multidisciplinary clinical as well as basic science team who work on the scenes and behind the scenes to make this disease more manageable. Thank you very much for your attention, and once again, thank you so much for the invitation.
Thank you very much for a very interesting lecture. So it's time for discussion and questions. Any questions? Please.
I'm asking the same question I'm always asking to Gianpaolo and to Giovanni and to the Italian guy. So everything is based in cardiac amyloidosis on BNP and anti-proBNP. And of course, I acknowledge the value baseline because really this is stratifying patient. But regarding the response, when is the right moment? Because in my experience, it's really going up and down very fast, especially in the first months. So not each time it's going up, it means that it's not responding. So when is the right moment to consider and to change of treatment? Should we rely so much on this or not?
So great question. I didn't, obviously, as Surbhi said, 20 minutes is not enough for any presentation that I have spent 30 years studying this for. But organ responses are very, very interesting to me, even in this day and age. Median time to 30% reduction in cardiac biomarkers or renal biomarkers occurs at 6 to 9 months following any hematologic response. So you have to wait for 6 to 9 months for at least a 30% reduction. The best organ response, meaning that normalization of biomarkers, either cardiac biomarkers or renal biomarkers, can take 2 to 3 years, 36 months. So I think that, what I always feel is that one must stay focused with our clone-directed therapies in obtaining a very, very stringent hematologic response within the first month or two. And the organs we have to support, I didn't really have a slide, but the supportive care is critical in managing these patients, because if you can manage their heart and kidneys appropriately with reduction in edema, reduction in congestive heart failure symptoms, I think then the clone-directed therapy will have a chance to really work. And I think also there is a bit of a pathophysiological question as well, because it is the mechanism 1, which is disruption of the architecture of the organs, or is it mechanism number 2, which is proteotoxicity of the soluble precursor protein? And I think both play a role, because your ECV on MRI is going to take at least a year to improve. GLS is going to take at least 15 months to improve. And I think those are related to the disruption of the architecture because of amyloid fibril deposition. I think the proteotoxicity is going to get better, which is measured by the biomarkers. So, but it is a very, very, organs are the most difficult to understand.
Question from Professor Jurczyszyszyn. Oh.
My question is regarding your view, because a year ago exactly, it was Polina Stepinski here with very nice talk about CAR T-cell. Israel experienced the most in the world, I think. Do you have any experience in your center with CAR T-cell? And another point is regarding venetoclax of the dose and the combination and your experience in this.
So CAR T cells, I don't have any personal experience, but I do know the data from Israel. 11 patients so far have been treated with their academic homegrown CAR T, and 100% hematologic response rates, but 6 deaths, despite achieving a hematologic response. 1 was related to bad COVID, and I think other 5 were related to bad organ dysfunction. Again, median lines of therapy, like SURBHI said, were 7 or 8 prior to offering CAR-T, so we don't know. The clinical trials are being designed. My personal experience that 3 patients have received cilta-cel for AL amyloidosis because their plasma cell burden was 15%, and I was able to get them done, not at my institution, at Mass General Hospital. And 1 person has the worst delayed neurotoxicity ever meaning like, oh my God. And other 2 are not alive. 1 died from a very bad infection, and the other person from very bad cytopenias. We didn't have stem cells. Stem cells were collected in 1998 when I was a first-year fellow. So yes, we didn't have those. So again, yes. And venetoclax dose, again, I hope there's nobody from AbbVie here, but AbbVie has never, ever really taken our proposals to do a prospective clinical trial for venetoclax in AL amyloidosis. There have been, all of us have been using it. I usually start out at 200 and then gradually go up to 400. There are 2 clinical trials that I'm currently participating in. One of them is a ETCTN, early therapeutic, it's an NCI trial. And in that, the dose of venetoclax is 400. It is combined with ixazomib, but I don't think you really need a partner to venetoclax. If you have 1114, within first 3 months, you are in deep CR. And most of my patients are MRD negative CRs.
So last question from Professor Sidana, please.
Great talk, as always. Even with the Andromeda study, there is a small amount of patients, 20-25%, who don't get into a VGPR. So what's your next line of therapy for them, both for transplant eligible and ineligible patients?
So, that is the biggest unmet need. And, the organ responses in Andromeda at 18 months were only 53 and 58%. So not all patients have organ response either, and that is what is going to affect their quality of life and overall survival. But, again, the next line of therapy post-Andromeda is always a clinical trial. And I say this over and over again, and, my paper is going to come out in Blood Advances, my journey of 30 years in clinical research in AL amyloidosis. I've enrolled 642 subjects in clinical trials with AL amyloidosis at one single institution, one-handedly as a PI with this. So, I said, this is my journey, and this probably would be my last paper in my career. But, it is still, the racial and ethnic diversity in 642 patients was 11%, 12%. So again, we are not yet there. But, I would say that clinical trials has what has really advanced the science. So clinical trials are critically important. Immunomodulatory agents, I didn't even talk about. We don't like it. I think POM is better tolerated than lenalidomide, just because lenalidomide MTD, maximally tolerated dose in AL amyloidosis, is 15 milligrams rather than 25 milligrams. So if depends. If they've had 2 or 3 years of achievement of hematologic response and then progression, I may try DARA again, DARA-based treatment. If they are progressing while on DARA, then maybe pomalidomide-based treatment. Obviously, if they're stem cell transplant eligible, then I would offer them stem cell transplant. Venetoclax, if they're, Suzanne Lynch would say venetoclax, because, and bispecific antibodies. I don't think you really need, till progression. I've treated several patients off-label, offline, off-clinical trial with bispecific. I've done 2 cycles and they are in CR. I don't know when they're all going to relapse, but it is because the level of plasma cell dyscrasia is so low that 2 cycles of teclistamab and you are home free.
Thank you, and congrats, 600 plus patients. That's so remarkable in AL amyloid trials. So congrats. Yeah.
Thank you very much. Thank you for beautiful words, sentences concerning Poland and Kraków. Thank you very much for these words.
Unfortunately, we have to proceed. I have an honor to invite Professor Aaron CIECHANOVER, whose research actually paved the way for the third major revolution in the treatment of multiple myeloma after introduction of cyclophosphamide and melphalan in 50s, then bone marrow transplantation, and then discovery of proteasome led to discovery of proteasome inhibitors, and they actually were the game changer in treatment of multiple myeloma. Professor CIECHANOVER, the floor is yours.
Thank you. Good afternoon. As a matter of fact, I didn't mean to make any revolution in any treatment, because we started from a curiosity of how proteins are degraded, and then it turned out to become a platform for drug development, mostly indeed for multiple myeloma and for amyloidosis, but now it broadens in a big way. So thank you very much, Artur, for inviting me here. And what I'll do, I'll give you the background of all the drugs that did this revolution, though we had nothing to do with the drugs. We didn't develop them, but we discovered the targets. So proteolysis in the body is going on, as you know, in several places. In the digestive tract, it's extracorporeal and non-specific. All the proteins that come in are degraded to amino acids that are being absorbed to build our own proteins. In the intracorporeal, in the body, but outside of the cells, for example, the blood coagulation system, they are very specific systems like the trypsin, antitrypsin, the blood coagulation system, which is a cascade of proteolytic events, ending up with a conversion of fibrinogen to fibrin. And then inside the cell, there are also several systems. One of them is the lysosome, of course, that was discovered by Christian de Diva. I'm going to talk about him later. And the other one is, of course, the autophagy, which is related to the lysosome. And then the apoptotic system that contains several proteases, like the caspases and so on. And the question that we asked when I was a graduate student with Avram Hershko after almost completing my residency in surgery, so I jumped directly from surgery to the lab, was how proteins are degraded specifically. Means not en masse, only proteins that need to be degraded, for example, misfolded, mutated proteins or proteins that completed their function, are degraded while sparing all other proteins, which is a difficult question because proteins are known to be destructive. They are non-discriminatory unless they are very specific, like the one that cleaves fibrinogen to fibrin, but then how all the zillion proteins are degraded once they get mutated, misfolded, denatured, and so on and so forth. And that required a special system, but the involvement was quite gradual. So the founder of the field was Rudolf Schönheimer, a Jewish German scientist that was expelled from his institute in Freiburg and moved to the United States during a period that was gathered into a book that is called Hitler's Gift. Hitler's Gift is kind of the gift that Hitler gave to the West in the shape of this Jewish scientist that went to the UK, but mostly to the United States, and converted the American science from being descriptive into being mechanistic, and also made English the language of science rather than German that really dominated a lot of the field at that time. And what people noted about protein degradation in the cell, that it requires metabolic energy, which didn't make any thermodynamic sense because proteins are source of energy in our digestive tract. You know, every protein, every digestion of a gram of a protein provides us with 4 kilocalories. The same for sugars. Lipids provide us with 9 kilocalories per gram. And here you see, I don't have a laser pointer, that if you are doing an experiment, you are pulsing liver slices with labeled methionine, and then you are looking for the release of the labeled methionine from the already synthesized proteins, you see that normally curve A describes the release of free methionine. I'm going back to the 50s. But if you trap the oxygen in the incubator and replace it with nitrogen, it's all going down to D. So protein degradation, nevertheless, in the cell requires metabolic energy, which tells us actually a story that we learn to understand very carefully, that all the processes in the cell that are controlled and regulated need metabolic energy. The cell, the coin that the cell pays for regulation is always with energy, because in the digestive tract, you know, you can put whatever protein, they will be just disappear in a few minutes into amino acids. No energy is required. On the contrary, as I said, energy is being taken from the protein. But then people started to notice, we are jumping from the 50s to the mid-70s, the degradation is specific, that each protein has its own story. So you can see the different proteins change in their half-lifetime. This is the measure that people in the degradation field are monitoring stability of proteins from several minutes to ornithine decarboxylase. But meanwhile, we learned also that all the oncogene P53 or tumor suppressor, P53 or oncogenes like MYC, RAS, JUN, and others have very short half-lifetime. So typically structural proteins are living for long. Hemoglobin is not a structural protein, but nevertheless it lives for 120 days until the red blood cells are destroyed in the reticuloendothelial system in the spleen. But regulatory protein for fine-tuning are having a half-lifetime which is very short. They are turning over very quickly in order to enable tuning of the level according to rapid changing needs of the cell. And you see it's going from few minutes all the way to few hours and days even, which told us that there must be behind a system that should recognize proteins that are destined for degradation and was still not known. So we diverted to the reticulocyte. We knew that the reticulocyte, the precursor of the red blood cell, doesn't have any lysosome. It's already ejected the lysosome along with the nucleus and the DNA, but nevertheless it still degrades its own machineries to leave at the end a very limited set of proteins, the glycolytic proteins and hemoglobin, of course, and then starting to circulate for 120 days in the circulation, carrying oxygen and carbon dioxide to different directions. And we published our first paper in '78. I was a graduate student with Avram Hershko, and this is indeed the most important paper I ever published. You won't believe it, the impact factor of this journal. At that time, there was no impact factor, so we couldn't bother more. Is about 2.5, I think. I don't look anymore. And we really described the system that we were interested in. We didn't know how specific it is, but we described in potential something that may answer the question of specificity. And what is it? It was a single table. So typically proteases are sole dancers. They can dance by themselves. Take trypsin, it will digest any protein that have any aromatic amino acid. It will cleave it on the right side, on the carboxy group. Take chymotrypsin, it will do the same for aromatic amino acids. So typically take catepsin, take all the proteins, they can digest protein as a solo dancer. This was already a diversion. So we took the reticulocyte lysate that doesn't have a lysosome anymore, and we used just an artificial, we labeled globin artificially with tritium, doesn't matter, we used numerous substrate, and indeed, in an ATP-dependent manner, we got degradation. So we got 7-fold degradation increase, from 1.5 to 10. Then we separated the lysate because we were at that time biochemists. We are still biochemists, but now we are using also animal models, of course, and molecular biology, and so on. So we wanted to understand the enzyme, this particular protease that can degrade, but in an ATP-dependent mode. There was not a known protease like that at that time. So we separated the lysate, which contains numerous proteins, on a column, doesn't matter, on an anion exchange column, into protein that came through the column, didn't adsorb to it, and protein that stuck to the column, and we had to desorb them with high salt. Very simple biochemistry of almost kindergarten. So, and we got two fractions, fraction 1 and fraction 2. And you see that neither of the fraction did have any activity. Or fraction 2, the one that was dissolved with salt, had some activity. But we had to combine the two in order to get the activity back. This was already a paradigm shift. Was not known at the field of proteolysis. And who told us that fraction 1 has only one component? Maybe it has one A and one B and one C. And maybe one A, if we'll ever find it, have one A prime and one A2 prime. And the same for fraction 2. The once you divert from the number 1, you are in an endless world. So the number becomes infinite. And indeed, when I left the lab after 5 years, I left behind 12 factors, 12 different factors that had to be at the same time in the same tube in order to degrade the protein. But not only that we had names for them by 1, 2, 3, and 4, but we knew exactly which is doing what and at what order. And I'll show you some of them are components of the proteasome, the 20S, the 19S, subunits of the proteasome, because we somehow separated them artificially. We didn't know what we are doing, all what we did is going to the cold room, separating on a column and make complementation, and then did all kinds of time curves in order to see who doesn't need time to work and who needs time to work, which means it comes a little bit later. So it was kind of I would say, biochemistry at its best. Anyway, at the end of the story, without going into details, because the end came in 2000 in a Nature paper, the first exposure of the human genome, the ubiquitin system contains almost 2,000 proteins, the system that we discovered. It's the biggest system in the database. It serves not only for protein degradation, it serves numerous other non-proteolytic functions, but it is the #1 regulated system that removes proteins that are either damaged or are not needed anymore, like transcription factor, for example, the one that code for the antibodies to coronavirus. Once we are immunized and there is no virus, why should we produce antibodies? We can take the transcription factor away, degrade them, and keep the memory in immune cells. We don't need factory of antibodies to be generated, B cells that will generate antibodies all the time. So the system is like that. You have a target protein that needs to be degraded. It has to be signed. It has to be assigned for degradation, in this case by double phosphorylation. I like this double phosphorylation because it's the I kappa B alpha of the NF kappa B transcription factor, but it can be anything that somehow sticks it, makes it a victim to the ubiquitin system. It binds to a protein called E3, or ubiquitin ligase. We'll talk about the ubiquitin ligases in a minute. And this is the beginning of the end of this protein. The ubiquitin ligase is the enzyme that binds ubiquitin to the target substrate. It's part of the cascade of the ubiquitin system. But the beginning is with an E1. It's called ubiquitin activating enzyme. It takes a small protein called ubiquitin, activates it in an energy-dependent manner. We solved all the biochemical pathways, well known now. From E1, it jumps to E2. There is one E1 in the database. There are about 50 E2s in the database, and there are close to 1,000 ubiquitin ligases, all destined to specific substrate, and it binds ubiquitin to the substrate in a covalent manner. The first ubiquitin to the substrate, the second to the first, the third to the second, and so on and so forth, to build a polyubiquitin chain, which was called by the Nobel Committee the kiss of death, because it kisses the protein to its death. By what? By the Valcade target, the proteasome. So here comes the proteasome. This is the target for the Valcade or for other proteasome inhibitors like carfilzomib and others. And Valcade and the proteasome doesn't recognize the substrate. It recognizes ubiquitin. And while ubiquitin binds to the proteasome, it brings the substrate in close proximity, so it enables the proteasome to digest the protein to peptides. So the protein, the ubiquitin come in close, the substrate opens, and digested to peptides. Now, the digestion to peptide is critically important for the immune system because all our immunity against viruses is based on this reaction, because peptides that are being released are being recognized by cytotoxic T cells. If they are self-peptides, nothing happens. But if they are foreign peptides, like of the coronavirus, of course you are activating the cytotoxic T cells. So the ubiquitin system is the main arm of the MHC class I immune system to degrade and to prepare antigens for presentation to the MHC, to the cytotoxic T cells. So this is one of the many functions of the ubiquitin system to discriminate, that enable the immune system to discriminate between self-peptides and non-self-peptides. Okay, let's jump quickly again to medicine. I never dreamt in my life that after being desperate from surgery, I will be back to medicine from the back door, but I am. So the system is hierarchical. You see there is a single E1 in the system, about 50 E2s, more close to 1,000 E3s, and they recognize about 10,000 different substances. So half of the proteome is now known from the literature to be degraded by the ubiquitin system. And of course, like any disease, if a protein goes below its level or go above its level, it's a disease. You know, you can talk about hemoglobin, you can talk about anemia on one side, on D-Guglielmo syndrome on another side. I mean, every protein that goes either up or down is a disease, and a disease must be solved, and the same with the ubiquitin system. So a protein can be under-degraded or over-degraded, and dependent on the protein will be the symptoms, and the disease will go very quickly. And we need protein degradation, as I said, for quality control, of course for control of processes like cell cycle. To move the cell cycle from one stage to another, you need to remove inhibitors and proteins that drive the cell from the cell cycle, and of course during differentiation or photogenesis. And for each of those, some diseases were discovered that are linked to defect in the ubiquitin system. Actually, there is a textbook now that is coming out summarizing all the diseases related to the ubiquitin system. So in the brain, of course, all the brain diseases, all the neurodegenerative diseases, with no exception, are diseases of quality control. Let it be tau in Alzheimer, let it be alpha-synuclein in Parkinson, let it be SOD in ALS, all of them with no exception. Let it be Huntington in Huntington. All these diseases are somehow defects in removing, they're not necessarily defects in the ubiquitin system, but defects in removing misfolded denatured protein. And of course, in cancer, an oncogenic protein that will be under-degraded on the left side will cause cancer. Think about mutated EGFR in breast cancer that will be under-degraded and will signal to the cell all the time. Or think about P53, a tumor suppressor on the right side that will be excessively degraded in human papillomavirus-induced cervical carcinoma. So you can see that on both sides, either excessive degradation or under-degradation is leading to a disease, and accordingly, the development of drugs that accompanies us. And the first drug, I don't have to tell you about it, it became already a history, came in the early 2000s, is proteasome inhibitor. By the way, it was discovered by a chance, so nobody really looked into it. It was kind of a repurposing program by the NCI that took a proteasome inhibitor and screened it against different cell lines, and they found that lymphocytes are B lymphocytes are extremely sensitive to it, to these cells. And here is Valcade, but as you know, there are much more advanced drugs today, though VRD is still kind of the triad that, as I understand, is good to start with, to put the patients on. And these are the clinical trials that were done by Bob Orlovsky and Ken Anderson. Ken is in the Dana-Farber, Bob is now in the MD Anderson, to show the efficacy of, at that time it was called PS341, on an IgA multiple myeloma. And you see how the patient is going to complete the response, and of course I don't have to explain you the bone marrow of this patient. Now, what is the mechanism of those drugs? We still don't know for sure. One mechanism is prevention of degradation of proteins that have to do with tumor suppression, with tumor promotion. So, for example, we can accelerate apoptosis via inhibiting the degradation of junk that goes up, or P21 or P27 that goes up, and decreasing proliferation and so on. So one explanation is a whole set of substances that are coming up, like NF-kappa B, that cannot be activated to become an oncogene, and so on and so forth. But another explanation, of course, is inducing of ER stress, because the IgG molecule, remember that the B cell become a huge factory for generation of antibodies. So if normally the cell is generating, let's say, 1,000 molecules per minute, and about 1% of them, like 10 molecules, are defective, which occurs in any synthesis, the ubiquitin system can still handle it. But if the abnormal B cells, if the malignant B cells is making million molecules a minute and 10,000 of them are abnormal, then the ubiquitin system is at its border. And if we inhibit the proteasome, and we don't inhibit it completely because it will be lethal to inhibit it completely, but we inhibit it in the schedule that people are using to about 30% of its level, the cell start to accumulate abnormal protein, inducing the ER stress and the unfolded protein response, the UPR, and induces apoptosis. So in one sense, all these inhibitors are not chemotherapeutic agents, or they're not chelating agents of DNA, and they can be combined potentially with other, at least when we are talking about other diseases in which the proteasome inhibitors are being tried nowadays. That's it? Well, it's shut down because I cannot even go back. So, okay, I can stop here. Basically, I just wanted to show you what's going on now in my lab, but I can stop here because the presentation stopped from being running, and I know that it stopped because I cannot even go back. But what I wanted to tell you very briefly is that we started from a curiosity, looking for a proteolytic system that will degrade proteins in a specific way, and all of a sudden we found ourselves on the highway of clinical trials and drug development, and it's still going on in a very significant pace. So thank you very much.
Before we will go to the questions, I will try, if you permit, try to explain what you said about the role of this in immunity. In short, antibodies have constant size. They are all the same. But antigens, proteins, are of different size. So there has to be a mechanism that will adjust size of the antigen to the size of antibody. And essentially, each protein has to be cut into the antigenic peptides that are composed of 9 to 12 anti-acids, and then amino acids, and then they are recognized by antibodies. So this is what is the importance for immunology, because otherwise there would not be possibility of recognizing of antigen by antibody. So this is the explanation. Then I have the first question is, I was actually curious why proteasome inhibitors do not work actually, at least I don't have knowledge about the evidence, in other neoplasia that is associated with large production of protein.
Well, I don't know the answer. It's very interesting because also the IMiDs like lenalidomide and pomalidomide also work only, and they work on a completely different mechanism. Actually, they work, I wanted to show it, but the slides didn't go on. The IMiDs are working by, they are products actually, they are molecular glues. They are binding the oncogenes, like the Z-fold protein, the zinc-fold protein into a ubiquitin ligase. So they force degradation by actually going upstream to the ligases. So the mechanism of IMiDs is completely different than the mechanism. And interesting that the two major drugs that were discovered based on the ubiquitin system are kind of very specific to multiple myeloma and also to amyloidosis. But I think that the answer about proteasome inhibitors is that the multiple myeloma is the unique disease by which you have a huge factory of proteins in the cell, and you accumulate abnormal proteins, which are normal products of the synthesis. But you accumulate it in such a high number that, and you inhibit the system that is supposed to degrade them, so they induce something completely else, which is the unfolded protein response. Mm-hmm. While other malignancies do not have this unique property.
Thank you very much.
There is another malignancy with so professional cells producing so much high amount of proteins, such as pancreatic cancer. It's also a typical cell that produces a lot of proteins, but it doesn't.
Yeah, but with pancreatic cancer, the PDAC, the problem is that the cancer itself surrounds itself with a shield that doesn't let chemotherapy go in. So the proteasome inhibitor is non-penetrable into PDAC. So this is a different story there with the pancreatic cancer. Yes?
Very nice presentation. I don't know what we're going to talk in the last slides, but I want to ask about PROTACs and these protein degraders. Do you think it's a next, like a game changer? Because most of it, like transcription factors, for example, they're not druggable. You cannot, so far you couldn't really make molecules to kill them, and they drive a lot of diseases,
so PROTACs,
including tumors.
Let me just talk about it. Actually, lenalidomide is not a PROTAC, it's an IMiD, but doesn't matter. The mechanism is the same. pomalidomide, all the derivatives of thalidomide are basically working on the same. So these are molecular glue. What is a molecular glue? It binds two things that don't relate to one another. If I want to take this microphone and hook it to the wall, I put the glue and can hook it to the wall, though the wall never talks to this microphone. So products are beheaded molecules. On one hand, they bind to a ubiquitin ligase, typically 1 or 2 ubiquitin ligases. The cereblon is one of them. Lenalidomide and pomalidomide bind to cereblon. You can bind it to MDM2. You can bind it to PVHL, which is involved in renal cell carcinoma. You can do a lot of things. And the other head binds to the substrate. So what people are doing and the companies are doing, they are screening huge libraries to high affinity binders to their target protein, like RAS. RAS is really on the map. And there are already degraders for RAS. They are entering clinical trials gradually. And RAS has been undruggable for generations. And so this molecule is a glue, and what the glue is doing, it brings it next to the ligase. Now, the ligase either recognizes substrate specifically or by vicinity. What the product is doing, it brings it by vicinity, and then the ligase doesn't know who he is, and it ubiquitinates it. Once it's ubiquitinated, the proteasome will recognize it and degrade it. So I think that the potential of products is huge, because you can drug in potential any target protein you like, provided that you'll find a high affinity binder to it and bind it, of course, to the ligase binder and the story. And I think that the first one is coming to the market. It's already was successful in phase 3. It's for the testosterone receptor in prostate cancer. It's coming up by Arvina, the company of Craig Cruz at Yale. So already the pioneer is doing its way into the clinic.
Thank you very much. If there is no more questions, we will cover.
It's a pleasure to introduce next speaker. The next speaker is Professor David VESOLE. Professor will be talking about T-cell redirecting antibody in patients with relapsed or refractory multiple myeloma. The stage is yours.
Thank you, everyone. Thank the organizers, my good friend Artur. He tells me it's my 7th visit here. I love Krakow. So it's always a pleasure to come here and be able to present the latest information to a very attentive audience, and it's really a pleasure to always to see the sights and sounds of Krakow. So I thank you for that opportunity always. So today my talk is on T-cell redirecting therapy, basically going to be on bispecifics with a little tiny touch on antibody drug conjugates. In the treatment of myeloma, I don't think you have access to any of these agents here in Poland, but they're certainly becoming very, very highly used in America, mainly because you already had a great talk from Dr. Sidana on CAR T cells, but essentially CAR T cells have to be performed at transplant centers, and the general oncology population doesn't always send their patients to transplant centers. In contrast, because bispecifics are off the shelf, they can be administered in local practices. So this is becoming a very, very highly used mode of treatment in the communities for patients with myeloma that are not being referred for CAR T cells, which I agree like 100% with Dr. Sidana's flow sheet of how she manages her patients. And I personally would have all my patients get CAR T cells if it's possible, but it's not always possible. So we've talked about a variety of immunotherapies in the treatment of myeloma. The first immunotherapy were the monoclonal antibodies, daratumumab, and now isatuximab is available as anti-CD38 monoclonal antibodies, and there's another antibody, elotuzumab, which is a SLAMF7 or a CS1 monoclonal antibody. Those have been approved now for close to over 5 years for at least daratumumab and elotuzumab. And then belantamab, the antibody drug conjugate, was approved for, it's a BCMA-directed antibody drug conjugate. It was approved and then subsequently taken off the market in the US. I'm not sure it's off the market in Europe. Is it available in Europe? Belantamab? Soon to be reapproved in the US based on a trial I'm going to show you in just a little bit. The two trials, one called the DREAM7, the other one, the Dream 8, and probably going to be reintroduced into our treatment armamentarium in the US as well. And that was out there as an antibody-drug conjugate. We already had excellent talks about CAR T cells. I'm not going to talk about the 2 different CAR T cells, and nor the other CAR T cells that are in development. But I am going to talk about bispecific antibodies. There currently are, in the US, there's 3 that are approved. 2 of them are BCMA-directed CAR T cells, and the other one is a GP5 CRD, approved CAR T cell. So this is the antibody-drug conjugate on the left, which is the belantamab, delivering its nuclear, I should say its radioactive or nuclear substance onto the antibody that has a BCMA target. If we had general oncologists here, there's a number of antibody-drug conjugates available to treat patients with solid tumors and a couple others with hematologic malignancies. And again, in the US, currently off the market, soon to be reintroduced to the market. We already heard about CAR T cells. And then we're going to talk about bispecific antibodies, which all of them use a CD3 combination with either right now the approved one or BCMA or the GP65RD option. And this is the basic setup for the bispecifics, another cartoon. And these are the ones that are currently available. Teclistamab and erlanimab are like first cousins as far as their efficacies are very similar. The toxicities are very similar. The overall response rates are really, for the most part, very similar. There's actually a whole list of other bispecifics that also target BCMA, and they're really all very comparable for the most part. There's differences sometimes in a little bit in the toxicities, a little bit difference in the scheduling of the treatments, but they're really all fairly close as far as their efficacy and toxicities. Teclistamab has a 3-step dosing. In the US, we're admitting it's recommended they be admitted to the hospital for the 3-step dosing schedule because of the potential for CRS, which I'm not going to go into any details, but I've got a couple of slides on CRS. Elrantamab has a 3-step also target dosing schedule, but they're only recommended to be in the hospital for the first 2 doses, and the 3rd dose can be given as an outpatient. And talquetamab, the GPCR5D, actually has 2 different dose options, either the final dose of 0.4 milligram per kilogram or the 0.8 milligram per kilogram. For the 0.8 milligram per kilogram, it's 4 steps, and for the 0.4 milligram per kilogram, it's 3 steps. So you're in the hospital for 7 to 9 days, depending on which of the options you choose. As it turns out, the 0.8 milligram per kilograms an every 2-week schedule, and that's the only one we use. We don't use the 0.4 in our practice. The other 2, the BCMA-directed ones, are weekly. They're both weekly for 6 months, and then if they're in a very good response or complete response, you can actually change them to every 2 weeks. In reality, I personally, and I'm assuming my colleagues probably do the same thing, after usually 2 cycles, the response rates to the bispecifics are very rapid. And usually after 2 months, I change them from either weekly to every 2 weeks, and by 4 months, I'm changing them to a monthly schedule. But even though that's not the FDA indication, they're shaking their heads. They do the same thing because it decreases the toxicity of these agents, and it's just more convenient. So even though they're approved, they're erlantamab and teclistamab approved weekly for 6 months, I don't give anyone 6 months of weekly drug. They're all getting less frequent dosing schedules than that. And the talquetamab as well, I use the 0.2 dose or every 2-week dosing, and usually by 2 months I switch them to every month. There's questions whether you can get by with even longer durations, although there's not a lot of studies on that. And unfortunately, there's no studies yet that are out there that say when you can discontinue these agents. There are some studies with one of the other bispecific. I'm going to show you very briefly one that's not approved called cevostamab, that they actually had a 1-year cutoff where they discontinued therapy. But for all practical purposes, most of the centers and the treating physicians are treating indefinitely with these drugs. I don't think it's necessary. I think there's a lot of complete remissions, and whether it's very debatable, and I think that's going to be our next talk on minimal residual disease, and if you can discontinue therapy after patients are MRD negative for a period of time. And that would be also applicable to the use of bispecifics. So the first one we're going to talk about is teclistamab. It was the first bispecific approved. It was approved for patients with more than four or more lines of therapy, even though the trial was 3 or more lines of therapy. There were 165 patients in the initial trial, and when you look at the data for the response rate, again, we already heard about CAR T cells. These don't get the same level of response as the CAR T cells. Ida-cel is in the mid-70s, and cilta-cel is over 95%. But these are patients who have essentially no other options available to them. The only other drug that's approved for 4 or more lines of therapy is selinexor, or Expovio, which is an XPO1 inhibitor, and that has a 25% response rate. So we went from 25% for the only approved drug to the CAR T cells, which we already alluded to the bispecifics, which are going to be in the 60 to 75% range for these patients who really don't have any other treatment options. So the response rate with this was 63%, the VGPR better with 60%. So this was very, very impressive data. And there are obviously side effects to the use of the bispecifics. The most common things that we see is CRS, but most of CRS is much less than what we see with CAR T cells. It's substantially less, and the neurotoxicity is substantially less for patients with bispecifics. It's not that it doesn't exist, but it's much less. I've seen 1 or 2 patients get cranial nerve palsies, Bell's palsies with the bispecifics, but it's a much less toxic regimen to use for at least the BCMA-targeted therapies to give the bispecifics over CAR T cells. When you look at this data set, CRS was 72%, and about a third of the patients required tocilizumab to reverse that. And the other option, which is easier to do, is steroids. We actually are giving steroids preemptively to see if we can just abrogate completely the CRS that we see with this. Neurotoxicity was 15%, but again, it's much less significant than what we've seen with the bispecifics, and I'm unaware, at least in our group, of seeing any late-term, really late-term Parkinsonisms. It has been described. There's a case of Guillain-Barré that's been described. I personally have never seen it. It was like 1 case in the whole data set. So there are some CRS and neurotoxicities that are potential with this. The biggest toxicity with the BCMA-targeted therapies is their immune compromise. And it's even more profound because unlike CAR T cells, usually by 6 months, their immune systems are relatively reconstituted, at least for a myeloma patient, which is never quite normal. But when you keep giving the drug over and over and over again, their immune systems never completely can compensate for the fact that they're having this CD3-directed BCMA-targeted bispecific antibody. So they can have chronic problems with cytopenias, and they have chronic problems with infections. As we're going to see on one of the next slides, actually it's on here, the infection risk with teclistamab of serious infections, grade 3, 4, is 35%. And I've seen patients be cytopenic for an extremely long period of time, which is also one of the reasons why we give the drugs less frequently than what the FDA indication is. Elrantamab, again, it's another BCMA-directed bispecific made from a different company. The response rate for this was 61%, almost identical. There was a little less infectious complications with this, and they do have some data in patients who had previous BCMA-targeted therapies, which I'm going to show you in a second, with all these agents of prior BCMA-targeted therapy getting a repeat-directed BCMA-targeted therapy. CRS with this was a little bit less. The last one was 72%. This was 56%. The neurotoxicity with this was a little bit less. I think a lot of it has to do with numbers of patients, and I don't really think that there's a major difference. We have opted to go mainly with erlantamab because they only have to be hospitalized for 3 days instead of 5 to 7 days, and it's just shorter period of hospitalization, and we're going with the erlantamab versus the teclistamab in most of our patients. Telketamab is the GPRC5D bispecific. Response rates with GPCR5D bispecifics, as you can see here, they had 2 different dose schedules. The one that are available are the 0.4 milligram per kilogram or the 0.8. The response rates are essentially the same. They're all in the 65 to 70% range. And this was a longer trial comparing the 0.4 to the 0.8, and again, the response rates are in the 65 to 70% range. Little bit different toxicity because unlike the BCMA target therapies, we do have receptors for GPCR5D in our nails, and we have them in our skin and oral pharynx. So unlike teclistamab and erlantamab, the BCMA target therapies, you can get nail changes, which is just a cosmetic thing. They can get rashes, but that's usually very transient. But they can get very bad dysgeusia, and they can have about a third of them have significant weight loss because of the dysgeusia. It may take weeks or months and may never go away because of this impact on their taste. And they also have a lot of problems with xerostomia. So they have dry mouth and they can't taste. Patients don't want to eat. They lose weight. So this is a completely different issue because of what it targets in the body. There is another one that's out that just had a New England Journal Clinical Oncology article on linvoseltamab. It's another BCMA targeted therapy. There's a variety of them out there. They have very similar or comparable outcomes as to the other ones. So when you look at a slide set of the different the ones that are out there, the most common BCMA targeted ones, what you see there when you look at the response columns, they're all in the 60-some% range. They all have problems with some cytopenias. They all have problems with infectious complications, and they're very similar. And there's a number in development. Some of them are only given once a month, but they're really comparable to the ones that are out there. What about combining a bispecific with a monoclonal antibody? This is the TRIM2 trial of teclistamab with daratumumab in relapsed refractory myeloma, 65 patients. And what you see here in this group of patients is that response rates are very good. Again, these are patients who are not refractory to either the anti-CD38 monoclonal antibody or the BCMA targeted therapy, and response rates are in the 70 to 100% range with this combination. So these drugs are being moved up from 4 or more lines of therapy, actually even to frontline therapies. So this is the wave of the future, is not bispecifics for relapse refractory patients. You know, we already know that CAR T cells have been improved from 4 or more lines of therapy to 1 to 3 or 2 to 4 lines of therapy. They're going to probably be moved up ultimately to first-line therapy. You know, there was a couple other trials that Dr. Sidana didn't talk about with comparing transplant to CAR T cell for newly diagnosed patients and then for non-transplant eligible of standard therapies versus CAR T cells. They're going to be moved up front, I'm fairly certain, and the same thing's going to probably be true for the bispecific antibodies as well. They're going to keep being moved up earlier in the disease course. There are a couple, or let's just show you the next one. The different bispecific, cevostamab is a FcRH5 targeted therapy. It's in phase 2 trials, looks very promising. In theory, you can go from one bispecific to the other bispecific, and when this one's approved, to a third bispecific because they're non-cross reactive. Results with cevostamab, a little bit less than what we saw with the other ones, but when they look at the dose that they actually plan to use, it's 56.7%. Again, it's about 60%. So these things are very potent. We talked very briefly about neurotoxicity and CRS. I'm going to skip that. And infection prophylaxis is very important. I'm not a big fan of giving Bactrim, sulfamethoxazole, for PC or PJP prophylaxis. I think PJP is relatively uncommon in myeloma back in the old days when we used to give VAD, vincristine adriamycin dex. We used to get more PJP, but with the current therapies, we actually very little of it. But these patients, as well as the CAR T-cell patients, all need to be on antiviral and anti-PJP prophylaxis. I also, because of the long-term neutropenia you sometimes get with these patients, is they need to go on antibacterial prophylaxis too if they're neutropenic. We do give them growth factors if they need it. So how do you compare bispecifics with CAR T cells? Well, again, CAR T cells have to be done at transplant centers, at least in the US, and I'm assuming everywhere else in the world. There's very few private practices that are going to be doing CAR T cells, but bispecifics are off the shelf, can be given anywhere. We used to have significant problems with manufacturing slots for CAR T cells. That's not a problem anymore, at least in our center, and I think most of the other centers can get CAR T cells, whatever number of slots they need. I think our group did 12 myeloma patients last month, and it's actually expected to even grow more than that for getting CAR T cells. But the bispecifics, and there are some manufacturing failures. It depends on which one, but it's in the 10 to 20% that don't meet specifications. And then there are patients that have very aggressive disease that you can't wait 4 to 6 weeks for CAR T cell manufacturing. You have to treat them with something. So some of those patients, even though I may prefer they get CAR T cells, they're just not eligible. And those are the patients we're giving the bispecifics to preferentially, are those that can't wait, are those patients who don't manufacture the adequate number of CAR T cells to be used. When you look at the difference between BCMA-targeted therapies, you look at CAR T cells, this has already been shown by Dr. Sidana, but when they've had prior exposure, which is the columns, let's just have a pointer, the prior exposure group, if they had prior bispecific antibody, and then they got, these are very small numbers, they're minuscule numbers, I need to point that out. But you can get some reaction again, some activity again in patients who've had previous BCMA-targeted therapies if you give them another BCMA-targeted therapy. As Dr. Sidana pointed out to you, if you have a relatively short interval, the likelihood of using the same type of target again is going to give you very poor results. So we're not big fans unless they have over a year, which is exactly what she put on her slide. If they have a year remission duration after a BCMA-targeted therapy, we will consider giving a BCMA-targeted therapy again, although for the most part, we probably would try the GPCR5D first. Let's skip these. And this is kind of the other way around. For those patients who had prior, again, it's just magnifying the likelihood of responding. If you had a prior BCMA-targeted therapy and then you got prior ADC, you can still have a 65% response rate, prior CAR T cell 60%, prior BCMA therapy 69%. So you can do this. It's just that they don't last very long. So this is a table, and you guys ought to have this in your programs, of the different tables for the different bispecifics, the different schedules, and those that are in development, and those that are a combination, including a study of talquetamab with teclistamab using 2 different bispecifics. I can't imagine what that does to someone's immune system and for how long. And then the one that I showed you before, the TRIM trial of daratumumab with teclistamab. And my last BCMA target therapy, which I alluded to earlier, is belantamab mafodotin, which is antibody drug conjugate. This is the DREAM-8 trial. I didn't put slides in of the DREAM-7 trial. The DREAM-7 trial is belantamab plus bortezomib, which was very appropriate to the talk we just had. And the DREAM-8 trial was belantamab plus pomalidomide. And they're comparing the belantamab-based therapies with standard therapies. And what they found here, overall response rate of the belantamab POM, 77% versus POM bortezomib, 72%. So these therapies can certainly be given. One of the issues with belantamab, I don't know if you use it here, is it causes keratopathy, and everyone has to see an ophthalmologist or an optometrist before every dose, because you have to watch for different grades of keratopathy. It's very difficult to find ophthalmologists in the real world who want to do this for us. Response rates at the 12-month, 71% with the belantamab-based therapy versus the pomalidomide bortezomib was only 51%. So based on the DREAM7 and DREAM8 data, it looks like this drug's going to be back on the market in the US very soon. So this is kind of what's happened over a period of time. Bortezomib, first approved in 2003, lenalidomide 2006, carfilzomib, I think it's 2014. When you look at the single agent, which no one uses single agents anymore for induction therapies and like, but then when you see CAR T cells, 70 to 100%, and with the bispecifics, it's in the essentially 60-some to 70% range. So you have to decide which one you're going to do. Part of it has to do with availability. It's a whole different question here in Europe about the availability of all these new agents because they cost a fortune. I'm not sure what my colleagues will tell you. The CAR T cells, we just had an analysis done. What they actually charge for a CAR T cell in America is about $500,000 for charges. That's not what they get paid, but that's what the charges are, is $500,000. But the bispecifics that I just showed you, even if you give them once or twice a month, or if you give it 4 times or weekly, we're talking about $50,000 US dollars a month for these drugs. So they're unbelievably expensive. So that has to all fall into the way you and the audience are going to treat patients if and when they become available to you, because the costs are prohibitively high. So question is which we already alluded to, what's the best sequence of bispecific versus CAR T cell? I personally am always going to go with the CAR T cell first. Should we do, which none of us addressed today, including CAR T cells, should you do maintenance therapy after CAR T cells, particularly if they're done earlier in the disease course? Should we give all those patients daratumumab for maintenance, or daratumumab Revlimid or lenalidomide for maintenance? There are trials looking at that. There are also trials looking at bispecifics as maintenance therapy after autologous transplants. There's a couple trials out there doing that. So the questions of sequencing, what about antibody drug conjugates? Again, do you want to mix and match different BCMA targeted therapies? So these are all questions that take time to figure it out. Dr. Sidana already mentioned, we don't know why these drugs lose their efficacy, whether it's T-cell exhaustion, lack of antigen presentation, unlike CAR T-cells, which die out and generally by 6 months, except for those late patients with neurotoxicity where they may last longer. These drugs are given every week or every 2 weeks, so they're not, that's not the issue, but whether it's T-cell exhaustion or not is very likely to be the case. So this is kind of one of the potential paradigms for treatment. Frontline therapy, for the most part, I don't know, we don't have anyone talking about smoldering myeloma today, but symptomatic myeloma in most places, it's quadruplet therapy, not triplet therapy, based on recent approval of daratumumab for frontline therapy. So quadruplet induction, transplant still considered the standard of care, whether it's going to be necessary based on this trial called the CARTITUDE-6 trial, where they're comparing transplant with CAR T-cell. I don't know. That trial has not yet met its accrual and probably won't read out for a while. Consolidation therapy, which is what I give for my high-risk patients. I'm not sure standard risk patients really need it much. And then maintenance therapy, and that's changing drastically based on the Perseus trial done predominantly in Europe of daratumumab Revlimid, and there's another trial that was done in the US and Europe called the Aruga trial, which is also a daratumumab-based regimen. And then for first relapse, you can go right to a CAR T-cell, and I'm sure in the not-too-distant future that it'll be to a bispecific as well. And then we still need, because we still don't think we're curing patients, at least I don't think I'm curing patients, we still need something for late relapses. And this is just another slide of that. There are some drugs in development. Dr. Vaishali, or Dr. Sanchorowala talked about venetoclax. There's certainly activity of venetoclax in myeloma patients who have 11-14. There are actually some activity even in the non-11-14s if they're BCL2 expressors. There's a whole new list of drugs that are cell mods. They're cousins of the immunomodulatory drugs. Iberdomide and mezigdomide are out there. So there's certainly a lot of things on the horizon to be able to offer our patients in the future. And with that, I will conclude. Thank you.
Thank you, Professor. Questions?
Thank you, David, for the wonderful comparison between effectiveness of CAR T cells and bispecific. As far as I know, the main difference between the two attitudes is that CAR T cells multiply and persist for a long time in the peripheral blood of recipients. For how long? 1 year probably?
No, CAR T cells, we could ask Dr. Sidana, most of them are usually, they've done the pharmacokinetics, they're usually gone by 6 months. There are CAR T cells, particularly there's one that's called a BB2127. They're supposed to be longer-term memory CAR T cells. They really haven't panned out that well as far as outcomes. We could ask the CAR T cell expert, but they really don't last very long. There may be some late-term ones.
Last for 6 months. Bispecific lasts for 2 weeks, probably.
Yeah.
Something like that, because we have to repeat it. So you suggest that it's better to use CAR T cells a priori and afterwards bispecific. So you think after the 6 months, or only when patient relapse, so it could be considered as a consolidation or continuation of previous T cell directed therapy against plasmacytes. And as you suggested, bispecific is a little bit less toxic generally because T cell became exhausted, there is lymphopenia more than after CAR T cells.
Are you guys aware of any trials where they're giving late-term consolidations or maintenance? I'm not sure. I'm not aware of any trial that's looking. Part of it has to do with money. Which is money drives the world, right? I'm not aware of any late term. All the maintenance trials are usually between 2 and 4 months. So I don't know if you had somebody in remission, you could get from the pharmaceutical companies to say, well, we're going to give you our very expensive drug for you to do a trial like that.
And do you exclude from both kind of therapy patient with a priori to even multimyeloma, autoimmune diseases?
So for bispecifics, bispecifics, we have bispecifics in a lot of other diseases, and there's CAR T cells in we didn't even touch on that. CAR T cells in all kinds of solid tumors. There's CAR T cells in lymphoma. Dr. Sanchorowala didn't mention there's actually a very nice trial of CAR T cells in amyloid. It's not a whole lot of patients, but it looked very, very, very promising as well. So the CAR T cells are the wave of the future for not just hematologic malignancies, but also solid tumors.
Okay, thank you.
So I presume that anti-BCMA bispecific antibodies also go through the route to the central nervous system. So have you seen some cases with Parkinsonism with bispecific antibodies?
I haven't seen any of the Parkinson's, nor have I seen if you look at the studies, the teclistamab study, I think they had 1 case of Parkinsonism and they had 1 case of Guillain-Barré reported in one of the, I think, 165 patients. So it's less than 1%. I personally have not seen that. I've seen a couple. I think I've seen 2 Bell's palsies with bispecifics, and that's it. I personally have not seen any of the late-term neurotoxicity.
You have a myeloma patient who is receiving BCMA-targeted bispecific and now is in progression. Do you forget it and try something else, or you try to add something on top?
So generally we, again, the ones that we're treating bispecifics that are the ones that we can't get CAR T cells, and we'll generally go from a BCMA bispecific to the GPCR5D bispecific. And it's easy enough that patients are not too thrilled because they have to be hospitalized again for probably 9 days for getting the bispecific. We go from one to the other though. And that's actually our go-to after they've failed a bispecific. If they had a CAR T cell, just as was mentioned previously, it's the only CAR T cells right now that are available are the BCMA targeted ones. Our next line of therapy would probably be the GPCR5D bispecific for that population.
You mentioned about STREAM-2 trial, its beautiful results, and you mentioned that probably future we have teclistamab and daratumumab in the first line. Patient needs holidays. Do you think 1 year of this treatment will be enough, or 2 years? How do you think in first line?
So I can only speculate, and again, we're going to have someone talk to us about MRD and if you can safely discontinue treatment after you're MRD negative. We don't have any data yet with the bispecifics, but I think that the theory would probably hold true. On the other hand, you're dealing with a relapse refractory group, but you're asking about frontline. But in relapse refractory, do you really feel comfortable stopping therapy in somebody who's had 4 or more lines of therapy because they're MRD negative? I'm going like, I'm not sure I would buy that. But in the frontline setting, I think that would, since they have so many options available to them, I think that would be a very reasonable endpoint. But I don't even know if there are some trials, but they're in relapse setting of discontinuing bispecifics. But none of them, I don't think any of the upfront ones are discontinuing them in the upfront bispecific trials.
Okay, thank
you. If no further questions, we have to close the session. Artur, would you like to make some announcement as an organizer?
Okay, thank you very much. And we'll have a break until 3:10, and we'll start at 3:10. But now I would like to ask you to the podium for memorable photo, because our guests are leaving after this session. So please go to the podium and we'll do a photo with our photograph. Thank you.